So by now, hopefully you know that your kidneys help maintain our balance of electrolytes. So sodium, we talked about potassium, calcium, magnesium, all that stuff. And in this video, we're going to talk about what might happen if you have too much sodium or too little sodium, too much potassium or too little potassium. This video is all about electrolyte disturbances. And we'll start with sodium first because sodium is kind of the most important one. So sodium. Too little sodium we call hyponatremia. Too much sodium we call hypernatremia. So let's talk about too low of sodium first. You can get hyponatremia from a couple of ways. So you can just have, I guess, loss of salt. But one of the most important things you should know is you can also get hyponatremia from too much water. If you have too much water in your body, it kind of dilutes the salt, right? Causes hyponatremia. And so finding out the fluid levels in the body is very important. That way we can break down hyponatremia into 3 different categories. We can break it down into having too much water in the body, hypervolemic, too little water in the body, hypovolemic, or maybe you have decreased salt, but you have a normal level of fluid in the body. We call that Euvolemic. All right, so hypervolemic, you have too much fluid in the body, and that's diluting the salt, causing that hyponatremia. What causes the increased fluid? Common causes, things like organ failure, especially heart failure. Yeah, you get fluid overloaded in heart failure, so I'll just write organ failure. Hypovolemia, you're losing salt and you're also losing a lot of water. All right, so you're dry and you're hyponatremic. What can cause that? One of the big ones is going to be diuretics. All right, you can also get things like vomiting, diarrhea, especially diarrhea because you're losing a lot of fluid and you're also losing a lot of electrolytes. So diarrhea, low aldosterone. Do you remember what aldosterone does? Do you remember what it does? Hopefully you do. It works on your ENaC channel. And that took in sodium and pumped out hydrogen, pumped out potassium, right? Hopefully I just recap. This video is going to be a lot of recap. So if you don't have aldosterone, then you can't take in sodium. You lose that sodium. You lose that sodium and you pee, and with it water follows, so you pee a lot. So you're losing sodium, you're losing volume, you're hypovolemic, hyponatremic. Got it? Good. Low aldosterone. Euvolemic is kind of funny. Euvolemic is due to inappropriate amounts of ADH. Sometimes we call it syndrome of inappropriate ADH, SIADH. You know what I'm going to ask you, what does ADH do? What does ADH do? So pause the video, tell me everything you know about ADH. Give you just a minute, a second. ADH, you hopefully said, works on your V2 receptors, increases aquaporin, that's the water channel, and you suck up water. Yeah, you retain water. So you retain H2O. And you're thinking, you retain water, you just said this is euvolemic, this is normal fluid levels. Well, you just said you retain water. How do you get back to normal fluid levels? Well, what's the counter-regulatory mechanism of things like RAS and things like ADH? Hopefully you remember. When you have too much fluid, then your heart gets filled with fluid and it stretches and stretches. And it releases a couple of hormones. Your atria release AMP, your ventricles release BNP. And that helps you lose water and also helps you lose salt. So ADH retains water, and then the counter-regulatory mechanisms lose water, so these cancel out, and thus you're back to normal volume level. However, you're still losing salt, and that causes euvolemic hyponatremia. Hopefully that makes sense. So euvolemic hyponatremia is due to SIADH, increased ADH for whatever reason, and in fact, anytime you have really severe hyponatremia is usually SIADH. Now, what causes that inappropriate ADH in the first place? One of the most common causes is lung cancer, in particular small cell lung cancer. You know I'm going to ask you. Hopefully you did respiratory already, so tell me everything you know about small cell lung cancer. Everything. And I mean everything. Like down to its markers, down to its neoplastic syndromes. If you can do that, then you're in good shape for this step. If you can't, that's all right. Just, recap it, come back to this video, try it again. Another thing that can cause SIADH is going to be CNS lesions or trauma to the head. ADH, what do you think ADH is made? Isn't it made in your pituitary? And so CNS lesions can cause it, and then lastly, one of the most common things is meds. So if a patient comes in really severe hyponatremia, like way below 120, then you're thinking SIADH. So you ask them, do you smoke? If they say no, kind of roll that out. Any recent head trauma, dizziness, all that stuff, kind of roll out CNS lesion. And if they say no to that, then you just check their meds because it's something probably dealing with their meds. And that causes hyponatremia. Now, what's the treatment for SIADH? You're going to give an ADH antagonist. That just makes sense. The one you need to know is the mecloxylene. That's an ADH antagonist that kind of blocks that ADH. Makes perfect sense. That is hyponatremia. Let's talk about hypernatremia. Too much salt or loss of water. If you lose that water, then you kind of get dry and all that salt kind of builds up, yeah? So, here, ADH rears its ugly head again. If you're losing a ton of water in your urine, does that mean you have a lot of ADH or no ADH? But what does ADH do? It retains water. So if you're not doing that, then you have no ADH. So something's wrong with ADH. You have low ADH. That's just one of the causes. And this is one of the most important causes, so I'm just going to harp on this a little bit more. And you know you have low ADH because you can tell the patient, you know what, don't drink any water for this day. And in a normal patient, then when they pee, the urine should be concentrated. Yeah, it should be dark. But here, because you don't have ADH, you can't reabsorb water, your urine will stay dilute. It'll stay watery, be nice and clear. Okay, so I'll say, can't concentrate urine. You're just losing a ton of water. Now, what causes low ADH in the first place? Well, where's ADH made? I said it's made in your head, pituitary. So there's a CNS cause, where you just make low ADH. Sometimes you can have normal ADH and it goes around and goes around. ADH goes around and goes around, and it sees its receptor, its V2 receptor, but this receptor is mutated. This is my sign for mutated receptor. It's mutated and it can't bind. Yeah, something's wrong with your kidney receptors and it can't bind. Oh, your ADH is fine. It's in perfectly good levels, but it just can't bind. We call that nephrogenic cause. Nephrogenic cause. So I'll say mutated ADH. ADH receptor mutation. Now, how can you tell which one is which? Yeah, you're not going to like biopsy the little receptors, right? So you can just give the patient ADH. And if it fixes it, then you know it was due to a CNS cause. It was low ADH and now you fixed it. That ADH analog is called desmopressin. So you give desmopressin, you fix the problem, now the patient is peeing normal. Yeah, they're able to concentrate their urine. Their urine's nice and dark if they stop drinking water. But let's say you give the patient desmopressin, nothing happens. Then you know that there's something wrong with the receptor. Then it's nephrogenic. All right, desmopressin does not work. Why would it? The receptor isn't normal, so it doesn't work. Well, then how do you treat it if you can't get desmopressin? You're going to have to give some diuretics that work on the distal part of your kidneys. You're thinking, this person's peeing like a racehorse. We're going to give them diuretics. That's counterintuitive, and you're absolutely right. So why would we give them diuretics, especially that work on the last part of the nephron? Here's your Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. Yeah? ADH kind of works here. We're gonna give drugs like thiazides. Just pause the video, tell me where thiazides work, what do it do. Or we're gonna give drugs like amiloride, which is a potassium-sparing diuretic. And by blocking these channels, your body will freak out and say, the last half of my nephron just isn't doing its job. It's not working. I mean, the freaking receptors are out. We have diuretics that are blocking this. So I'm gonna really have to rely on my proximal side. And so it kind of upregulates these pumps and helps you reabsorb water and salt more proximally. Okay, and that's what we use. That's why we use it. Sounds kind of counterintuitive, but that's kind of the best things we can do for it. That is hypernatremia. Let me see if there's anything else I want to talk about on there. No, I think that does it. Let's move on to something else. Probably the second most important electrolyte that we talked about in this renal block is potassium. Potassium. And a lot of pumps use potassium. You have the classic sodium potassium ATP ACE pump, right? Every cell has that for its membrane potential. All right, membrane potential. Incredibly important. Pumps 3 sodium out and takes in 2 potassium. Right? And that kind of helps membrane potential. And you can imagine if something's wrong with your potassium, then your membrane potential is going to be all over the place. Okay? So it's very important for membrane potential. You have other pumps that use potassium. You have hydrogen potassium pump. And this is very important because it helps us with this regulation with acid bases. All right, so if you have acidosis, you have a ton of hydrogens. Acidosis, that's not good. We don't like acidosis. Your body will try and compensate for that. Say, you know what, I'm going to take in some acid. Take in some acid. Take in some acid. But I have to give another positive ion back, right? Otherwise, it would be unbalanced. And so it gives out potassium. So anytime you have acidosis, you actually pump out potassium. You get hyperkalemia. Right? And in alkalosis, it'd be completely different. It'd be completely different. In alkalosis, you don't have any hydrogen, and your body freaks out and says, I should probably pump some out. And so it pumps out some hydrogen. And again, it has to take something back in. It has to be an even trade. And takes in potassium. And so in alkalosis, you get hypokalemia. That's just, we're going to talk about that in a second, but just know this pump is very important. The hydrogen potassium pump. And then last but not least, you know we already talked about a lot of potassium in our kidney function. Yeah, I drew it out right here. You have cells that take in sodium, like your ENaC channels, take in sodium and pump out potassium and hydrogen. And we said aldosterone works on these, right? Hopefully nothing new there. So I'll just write renal function. All right. Let's just talk about, which one should I tackle first? I think hypokalemia will be the easiest one to tackle. Hypokalemia. This is in things like insulin overdose, too much insulin, or increased sympathetic drive. That's your fight or flight response. Boom, 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 heartbeat, all that stuff. Both of these, insulin takes in fuel, sympathetic drive basically activates the fight or flight system, and all these really needs this pump to be working, your ATP ACE pump. Yeah, so it will activate your ATP ACE pump. Activate ATP ACE, sodium potassium pump. And what does that do? Well, it takes in potassium, pumps out sodium. Takes in potassium, causes hypokalemia. You're taking that potassium into your cell. Okay? Alkalosis can cause this via this mechanism. We said that in alkalosis, you will pump out hydrogen. And to keep things even, you will take in potassium. Causes hypokalemia. You can have Hyperaldosteronism, whether it's from like a tumor or any other source. We said aldosterone activates this pump, takes in sodium, and pumps out potassium into your tubule, and you pee that out. You kind of get rid of that. Also, diuretics can cause you to lose potassium. Pee it out, lose that potassium. The only exception is going to be case-bearing. That's kind of the name of his game. And we'll talk about that in a second. But hyperaldosteronism, diuretics is something you got to know. And then vomiting and diarrhea, because you're just losing ions. You're just throwing it up or you're pulling it out. I don't know, I'm gesturing, but that can cause hypokalemia. Now, what happens when you get hypokalemia? Well, especially in this case, potassium comes in and it hyperpolarizes the cell. Hyperpolarizes the cell. Hyperpolarized cell. So it can hyperpolarize your smooth muscle, cause constipation, hyperpolarize your skeletal muscle, cause weakness. But probably the most important thing is that it messes with the membrane potential of your heart and causes arrhythmias. Arrhythmias. And you can see that on EKG because you start seeing U waves. U waves. And you absolutely have to be able to detect potassium changes on ECG. Always, always ask. So U waves are here's your QRS, and then U wave is a little wave at the bottom, at the end. So U wave. Picture will be in my notes if you're not able to discern a scribble. So make sure you know it cold. Always, always ask. Even in step 2. So that's hypokalemia. Let's talk about hyperkalemia for a second. Hyper. It'll be the exact opposite causes of hypo. And that just kind of makes sense. So whereas here you had increased insulin and increased sympathetic drive pushing that potassium in, if you have low insulin, low sympathetic drive, then you won't push it in. You can have changes to this pump. We said acidosis. Well, you have a lot of hydrogen out here. You'll take in hydrogen, pump out potassium. Causes hyperkalemia. And then we said case-bearing diuretics. Make sure you retain your potassium. And sometimes that's good. Sometimes it does it a little bit too well and you get hyperkalemia. Can you tell me what the case-bearing diuretics are? Where do they work? What are their side effects? If you're able to do that, then you're in a really good shape. If you're not able to do that, again, no worries. Just kind of recap my pharm video. You should be able to do that. Okay, that's case-bearing. And then one thing that you should know is cell lysis. Tumors, cancers, rhabdomyolysis, anytime cells died in the potassium in the cell will leak out. Okay, so that's a very important cause. Question I've seen, I'll just talk about a kid with leukemia, and then some they have hyperkalemia, and they might ask why. Cell lysis, okay? So I'll put a star over here. Something you should not forget. Now, what happens when you have hyperkalemia? Well, you have hyperkalemia, then it messes with your membrane potential and actually increases, becomes hyperactive. So you can have cramping, you can have paralysis. But the thing it shares in common with this hypokalemia friend is that when you're messing with the membrane potential, especially of your heart, you get arrhythmias. Easy thing to remember. Anytime you mess with potassium, no matter if it's high or low, you get arrhythmias. Okay. However, this looks a little bit different. Yeah, it's more excitable, so it has to look a little bit different. You get peaked T waves. You get QRS prolongation. And it can prolong so much that it starts to look like a sine wave. If you see it on ECG, think of hyperkalemia. Okay? Now, what's the treatment? Well, you're going to want to take in some of that potassium. So we can mess with these things. We can give insulin. We can give beta agonists like albuterol. We can give bicarb to work on this acidosis. I mean, we can give all these stuff. We can give diuretics not case-sparing diuretics, just normal diuretics, kind of pee out that potassium. And then we also give calcium. Calcium binds and it stabilizes the cell, stabilizes the heart. Make sure you don't get that arrhythmia. All right, probably, let me circle this. Calcium is probably the most important, kind of like the first thing you do before you start messing with that, because I mean, arrhythmias will kill someone right off the bat. So calcium is the first thing you do. Okay, and I think that does it for potassium. Yep, that does it for potassium. Now the next few electrolytes are going to be kind of a hodgepodge, just kind of the stranglers that we talked about when we were talking about the nephron. So things like calcium and phosphate and magnesium. I'll start with magnesium. Where is magnesium reabsorbed at? I wouldn't ask you that. So where's magnesium reabsorbed at? Tell me everything you know about that. Hopefully you said your loop of Henle, that was your thick ascending limb, via your huge sodium potassium chloride channel, right? And that caused the reabsorption of both magnesium and calcium. And if you block that with loop diuretics, then you lose that magnesium, that calcium, that potassium. Yeah. And that's exactly what happens. Anytime you have loop diuretics, you can lose magnesium, but you can also lose things like potassium and calcium. And you get the signs of this. In hypomagnesia, magnesium. In hypomagnesium, you will show signs of decreased potassium, hypokalemia. I'm not going to go through all that. We just went through all that, so hopefully you remember some of it. You also get decreased calcium. We'll talk about that in a second, but hypocalcemia causes tetany. So you'll start seeing things like tetany. You'll start seeing things like arrhythmias. All right, so just be aware of that. They go together like a horse and carriage. Okay? How about high magnesium? High magnesium, you get too much magnesium, it acts as a depressant. If you do OBGYN in your third year, you know that if you give too much magnesium, it acts as a depressant. You start losing their deep tendon reflexes. They start getting respiratory distress. They get cardiac distress. They can die from it. All right, depressant. The reason it's a depressant is that it binds to your calcium channels of your axon. Let me just draw it out. I don't know why I'm being so lazy. Binds to your calcium channels of your axon, stops the depolarization, stops the release of your neurotransmitters, and so it's a depressant. Yeah, so toxicity will show up as loss of deep tendon reflexes and respiratory and cardiac arrest. That's all I want to talk about for magnesium. Let's talk about phosphate for a second. Phosphate, where is phosphate reabsorbed? Where is phosphate reabsorbed? If you say your proximal convoluted tubule, gold star, gold star. And your phosphate is really important for things like bone formation. Yeah? If you have too much of it, high phosphate, then that's no good. You get kind of over bone formation. You can get calcification elsewhere. You get metastatic calcification. So, all right, increased calcification. It can also precipitate out as renal stones. If you have low phosphate, you can imagine that's not good. You're not able to make bones. So you have to have a fine balance. You get rickets, you get osteomalacia. One of the most common causes of low phosphate in your body is inappropriate PTH. That's your thyroid hormone, but a lot of people just mention it as phosphate thrashing hormone because it just makes you pee out all this phosphate. Last but not least, let's talk about calcium. Kind of already mentioned it, calcium. Seen in your bones, seen in your blood. You need to know that calcium helps stabilize the cell. Yeah, binds to stabilize the cell. That's why we gave calcium in hyperkalemia. To kind of stop the arrhythmias, right? If you have hypokalemia, if you have hypocalcemia, then your cells aren't stable. Cells aren't stable. And the way it stabilizes a cell is that it helps sodium sensitivity. If you have low calcium, then you have increased sodium sensitivity, and your membrane potentially gets out of whack. So I'll just write unstable. In hypocalcemia, don't you get seizures? Don't you get tetany? There are specific signs to test for tetany. If you tap on the face, they might grimace. If you squeeze around with a blood pressure cuff, they might carpal spasm. So tetany is a big one due to that unstable membrane potential. How about high calcium? Well, it gets overly stable. So it gets, do I want to write overly stable? I'll just write stable. So it gets stable. All right, so it can hyperstabilize cells, cause decrease in reflex, cause constipation because your cells aren't depolarizing in your stomach and working as they should, and that causes abdominal pain. Can cause altered mental state. Can cause bone pain from the excess calcification. All right, bone pain. Can cause renal stones. All that calcium can precipitate as stones. So it's like stones. Now, what causes all of this in the first place? Well, PTH is another big player. Again, PTH helps break down bones, kind of release calcium in the blood. And if you have too much PTH, then you can have high calcium. If you have too little, if you like take your PTH out in surgery, you can get hypocalcemia. A diuretic can cause hyperkalemia. Do you know what I'm getting at? What diuretic is that? If you said thiazide, you'd be right. Thiazide. Where does it work? DCT. Great. And then last but not least, acid bases can affect this. Acid base. Why is that? Is calcium not a positively charged ion? Don't these like to bind to negatively charged ions? The most common negatively charged protein in your body, or the most common protein period, is going to be albumin. Albumin. So it binds onto this. In acidosis, you have a lot of H+, and that extra H+ can bind the albumin and displace that. And displace it, and now it's free. And so you get hyperkalemia, so acidosis. What do you think will happen in alkalosis? Will be the exact opposite, right? You won't have that. More calcium will bind, and you will get hypocalcemic, or alkalosis. In fact, you can test this on yourself. Yes. Have you ever been anxious at a test? Oh, maybe it's step 1, and you're breathing heavy. You're breathing a lot. You're causing respiratory alkalosis. You're breathing out all that CO2. You're getting alkalotic. Your fingers might twitch. Your fingers might spasm. You're giving yourself tetany. So that's what happens when you're breathing a little bit too fast and you get kind of shaky. That does it for electrolyte disturbances. Hope you enjoyed the video. Hope it clarifies some things. See you next time.